تمام.
Okay, thanks يعني Maya and Hagar for this introduction and for your efforts in organizing such an event. And also I would like to thank IndabaXEgypt other organizers as well. So today, as May said, that I'm going to give a talk about this problem that most of Egyptian women face, which is the breast cancer. And I would like to give my talk today titled Machine Learning for Breast Cancer Management. That include three main phases and important phases like screening, diagnosis, and treatment planning. As May said, currently I'm assistant professor at Nile University, and also I'm the director of Artificial Intelligence program. It's a new program for undergraduate students at Nile University, and it's going to be launched next September. So it is a good opportunity to announce this in the beginning of my talk. So as I mentioned, that we're going to talk about three main steps or stages in the breast cancer patient management system, which is screening. بالعربي it is اللي هو الكشف المبكر يعني. الdiagnosis اللي هو التشخيص, والtreatment planning اللي هو this is the planning for any kind of treatment that would fit the patient. Okay, so in a glance, breast cancer is the most common cancer that would hit the women worldwide, and is the main cause for death among the other kinds of cancer. So it's kind of very threatening and very important kind of cancer. It is the second leading reason for female deaths worldwide. And as a local statistic, in Egypt, there is about 34% of Egyptian women suffer from breast cancer, which is quite surprising for me when I hear from Dr. Mohammed Omar, the director of Bahia Foundation in Egypt. So in a glance, I would like, first of all, to get you acquainted with the management, how doctors or physicians manage the breast cancer patients. So basically, there's kind of algorithm, like or workflow that they use to guide them. But actually, there's different variants in each country. But this is like the general form of an algorithm. So basically, we have two scenarios here. There's women who are aged between 35 and 40, and that depends on the country. Each country has its own standard. And those category of women or specific age, they are subject to, or actually they are having the right now to make like screening or to be admitted to screening program, which usually utilize a specific kind of imaging machine called mammogram. There is also another kind of patients who are arriving to the clinic with symptoms, or there is like some problems, and they are not yet admitted as or coming within those age category or age interval. So for the screening, there's mammogram is used. If it's normal, she's gonna come the next year to make the test again. And if she comes, for example, because she had some symptoms, they're gonna use a diagnostic mammogram and also another modality called ultrasound. And I'm gonna speak about the difference between them later on. If there's some suspicious about having a malignancy, اللي هو ورم خبيث وbenign, اللي هو الورم حميد يعني, they're gonna ask for a biopsy or عينة عشان they can investigate this using a specific digital microscope to test if there is an actual malignancy in this sample or not. In case of validated or confirmed malignancy, there are several kinds of treatment that they can receive. The most commonly one is the surgery that would require a removal of parts that's affected, or maybe the removal of the whole breast. The other option is the radiotherapy, اللي هو العلاج الإشعاعي, and the chemotherapy or adjunctive therapy that would require the admission of specific chemical medications. We're gonna, the topic of this talk is how machine learning or deep learning handle those different situations. But I can tell you from this point of view that we are needing in the whole workflow different imaging modality. We need mammogram, we need ultrasound, we need CT to plan for the surgery or the radiotherapy, and so on. So to continue our outline, I just finished the first two. So this is the good news. The second part is, the next part is we're gonna talk about the radiology role, which is the imaging modalities or the imaging diagnostic imaging tools that we could use in that field, and then the utilization of machine learning and the three main categories or the three main steps that we're going to talk about, and then we're going to conclude our talk for today. So what is radiology? Basically, radiology is the medical specialty that requires the usage or utilization of medical imaging in favor or in need to diagnose or actually plan any kind of treatment for the diseases. So there's different types of images that we could face, like X-ray, computed tomography, magnetic resonance imaging, or ultrasound. So basically, for the first type, which is the simplest, the cheapest, the fastest, is the X-ray, and the extension for the X-ray in women's health called mammography. So it utilizes the same technology, but in different settings. So basically, the mammography is, especially the screening part, examines both breasts using X-ray, but for each breast, we need to look at it from two different angles of views. That would add more information for us. So usually if you are looking at an object from one direction, you're going to see some accumulation of densities in one direction, like a projection. But if you have two points of view, that would add more information to the radiologist or oncologist. And oncologist here is the physician who works on oncology, or Dr. Awram. So basically for each patient, we produce, or the machine produce 4 different images. The 2 images are acquired like horizontally, and we call them craniocaudal. We have right and left for the right and left breast. And there is another 2 who are acquired in a different or specific angle, and they are called MLO, or mediolateral oblique view. So at the moment, we have 4 images for each patient. Okay, how physicians assess this kind of images? Luckily, there's an agreement between radiologists worldwide to use a specific schema called BI-RAD scheme. And BI-RAD scheme is basically it's like a set of categories or set of classes that they assign to define like a mammogram-based findings into a well-defined categories. For example, if the physician has looked at the images and he didn't see enough information, he could assign like category 0, like there's incomplete and it needs more information, needs more imaging and another assessments. If he is sure that this case is normal, so he's gonna assign category 1, which is negative, and category 2 for being sure about that this breast have or this patient has a benign tumor or benign mass. And if he has suspicious that this is not a probably benign, he's gonna assign a certain category and so on, until the 6th category, which is very important, and it's not assigned except if there is a validated biopsy. So when they reach to 4 or 5, like there is suspicious of having malignancy or waram khabis, they are advising with having a biopsy to extract some tissues, and because this is the gold standard, is to inspect the tissues under microscope. So if this is proven by biopsy, they can assign category 6. Okay, not only detection of abnormalities inside the breast is important, but also defining the nature of the breast itself, because it makes the task easier. So for example, we have 4 different kinds of images. They are they doesn't mean that this subject is patient or not. It's actually the development of the breast, maybe across the age, or maybe due to some hormone changes. So for example, in A, this is what we call like fatty, entirely fatty breast. And it's easy to see any problems inside, but there's also another kinds of breast, and that doesn't mean that this is patient, it's normal, but it makes it hard to see like if there's abnormality inside. And the second part, the second kind of image is called scattered areas of fibroglandular densities. And when the densities inside the breast increases, it makes the detection of a tumor inside this breast is quite a tough experience. So for 3 and D, that needs maybe a more experienced radiologist or physician, or really experienced to detect abnormalities in this kind of images. Okay, if there is a problem, or the suspicion of problem, the physician referred the patient to go and make an ultrasound. It's like the second step. And ultrasound utilizes or uses mechanical sound waves that hit specific organs, and according to the reflection of those sound waves, we can form an image. But actually, as you can see here in these images, it's quite hard to see information. You can't see geometrical information. You can't see the anatomy of the breast like this one, you can see the structure, the structure of the breast, but actually here you can't see this. Because the ultrasound sees a very small field of view, but actually supply a very detailed information. So in this image, there's something weird. It produces sound each time I switch between slides. So I don't know what I should do.
I think it's okay, Doctor. Yani, let me check. If I find some way to disable it, I'll do that. Okay.
Okay. So those three kinds of images are produced by ultrasound to refer to three kinds of images. So the one on the left is the normal image, the one in the middle where there is a benign tumor, and the one on the right side where is a malignant tumor. So the cool thing about ultrasound that the doctor uses a probe to make this kind of create this kind of images that goes directly to a specific slice and get this information. However, in the mammography, the imaging modality produces some X-rays, and those X-rays are going through a specific organ, so it gets like a summation of densities across the direction of each ray. So actually what we can see here is an accumulation of densities across a specific area. So that makes this kind of image produce or have a lot of information, but actually they are not related to specific X, Y, and Z location. Okay, the third kind of modality that we can use, the MRI or CT, and there's some preference for each one of them according to the cost and the quality of the images produced, but actually for women, we prefer to have MRI because for pregnant women, they cannot be exposed to like radiation from CT, but MRI use like magnetization of tissues, which is kind of healthy for people. Okay, so what is the benefits of utilization of AI in radiology? Basically, we have four main challenges that we would like to fix with AI. The first one is how to provide a more differentiated diagnosis, and that's basically by exposing more information from the images that we receive, and we can supply to the physician so he can see more, he can see better. So actually adjusting the contrast and brightness is kind of producing or providing a more differentiated diagnosis. The second way that AI can help radiologists is to pick up repetitive routine tasks. So as an example, and we're doing this in my company called Intexo, this image is, as you can see here, it's an animation for the heart, for a moving heart. And actually it's required to assess the health of the heart in this kind of animation is to track the muscle of the left ventricle of the heart and to make some measurements across the time frames. And to get like a physician who is really expensive to draw like two contours in all time frames in different slices, that's really kind of a repetitive task and really expensive, and would make a production of final report would take a lot of time. So actually AI would help in such tasks after revision from radiologists. A third thing that AI can help with is offering a second opinion. And this is actually the message that most of AI suppliers, AI algorithm suppliers should expose to their products, that they are forming a second opinion. We are not replacing physicians. And the last one, and the most important one, is the elimination of inter and intra-observer variability. And I'm not sure that the audience are aware of those two terms, but let me just define them very fast. So basically, when you have two radiologists analyzing the same case or writing reports for the same case, and they are having differences, this is inter-observer variability, variation between doctors seeing the same case. And if we have the same case offered to the same doctors 2 times randomly without his knowledge, and he makes some variation, this is what we call intra-observer variability. And actually measuring both of them is fair for you as an AI engineer to know how hard is your problem. So if you have a strong inter-observer variability, that means that it's a hard task. Most of physicians are are producing mistakes about those kind of cases. And if it's the same, if you have also a higher intra-observer variability, that would say that this problem is way harder than expected. So to wrap up the first part, AI techniques in medical imaging basically are having 2 main tasks to perform. Is to make image segmentation, like to locate where's the problem, where's the organ, doing some semantic segmentation in computer vision language, or localize where's the problem exactly in the image. And the other task is image classification identification, or maybe the third term that most of computer vision wouldn't hear about, which is stratification. This is what clinicians use to stratify between different kinds of patients. So the images on the right side are showing like how we perform segmentation for different problems, like here, the retinal images or the images of the retina of the eye. This is like skin cancer segmentation, and this is like a lung segmentation. And in case of classification, we have like two classes of images here, microscope images for a benign and malignant tumors. So during the next slides, we're gonna just discuss segmentation and classification. That's what we're gonna show in this work. So going back to our breast cancer management algorithm, we're gonna start by the first step here, which is screening using mammogram. And for this, I'm gonna show like 4 studies that look at this problem from different perspectives. So basically the first work that utilize kind of conventional method and conventional machine learning method by extracting features or having the features extracted by hand, or as we call it, handcrafted features. Nithya in this work has made a classification for normal and abnormal mammography images by calculating or extracting features called GLCM, gray level co-occurrence metrics, which are calculated. Then another 5 statistical measures have been calculated, like correlation, energy, entropy, homogeneity, and then those features are supplied to a next classifier. It's a multi-layer perceptron classifier that has been supplied to it directly, and a final classification objective was done to classify cases to normal or abnormal cancer. But actually, to just show you first how the images look like before classification. So in mammography, they were extracting like region of interest from the image, including suspicious areas. So for example, we have like 6 suspicious areas on the left where they are validated to be benign, and another 6 on the right side, which were malignant masses. And as you can see here, it could be easier to describe the shape of the benign masses or the benign masses from the malignant, where the benign have kind of round edges. However, in the malignant, they are having kind of spiky edges. But actually, there's some gray zone, some rows that they are malignant, but they look a bit like benign. So actually, handcrafting features, it's kind of competitive. It's not robust or reliable. So that's why we need like a convolutional convolutional layers that could describe on our behalf the real features that would correspond to a good classification. And this is exactly what the next study was all about. As you remember, we are having 2 main problems: classification and segmentation or detection. So classification is to say that the whole image is normal or abnormal, and the segmentation is to locate, or detection is to locate where's the affected areas inside this image. So actually, in this paper, Rebel and his team, they have utilized the faster RCNN. And faster RCNN, for the people who know it, is actually it is kind of the most effective algorithm at the moment for detection of abnormalities inside images or region of interest or object detection. That actually works like that. There is like an input image, and this input image is supplied to successive convolution layers to extract low-level features. And then there is this kind of very important network, which is called RBN, or Region Proposer Network, that takes those features and produce set of regions of interest inside the image. Let's say that those rows are defined by their anchor. Let's say like a top, for example, top left point. And those rows are supplied then to another classifier that takes these images and classify each one of them one by one. So for example, if the network took this like row, this is like the proposed row by this network, it can classify and say this is normal, so it's not going to be normal here, but actually this one was classified as benign or malignant, and then it was defined here by red square or by red row. So actually the RBN, it differs according to the application, but actually RBN here produce about 2,000 regions or rows, for the classifier to decide on which one of them to include and which not. But actually, as you can see here, if you remember that the patient in mammography would produce for it like 4 images, not a single image. So actually one drawback of this study that they were using just single image detection and classification. However, actually this graph shows the performance of that classifier. And I'm gonna get back to this graph later on when we are discussing the differences between their performance. But actually, let me get back to the point of view that we were utilizing a single image or a study. In this work done by Kim and his team, and actually they are producing a very, they are having like their own product called the LUNAT, and they are a South Korean team from Seoul University. They had this classification and detection architecture that utilized the 4 images at once. So for each image of them, there is like a ResNet backbone that extract features for each image, and then the combined features are gathered and used in one classifier to say that the whole case is are having cancer probability, yes or no. And not just that, the nice thing about this study that they're actually we're using only labels. So we need to detect some information inside the image and to detect where is the problem are in the image, like doing object recognition, but actually they don't have annotations. Annotations is like drawings that shows or masks that shows where's the abnormality in the image. So what they have done exactly here, that they used what's called global average pooling that would gather latest activation maps and get the weighted average of them. And it's expected that the most affected receptive field by the specific class that we are searching for gonna have a strong activation or activation of values in these areas, and accordingly they can see such an images that have like where is exactly the part that contributed to the classification of this case. And actually they have this very nice result of reducing about 90% of area under the ROC curve. And what is the ROC curve? Just to make sure that everyone, that we're on the same page. Basically, when we are assessing the accuracy of a specific classifier, we create such a graph which called ROC. An ROC curve have on x-axis like the sensitivity or the true positive rate, and on the y-axis and on the x-axis there is the false positive rate. And basically, when we measure the area below this curve, that shows us if this classifier is doing good or bad. Okay. So moving to the last study in the first part of the mammography, there's this very interesting study that actually tried to solve the problem of the last couple of studies where he have some annotations like masks, and he have other patient data sets that doesn't have annotation, just have labels, like if this whole patient is good or bad. So what he had done at this work, he trained like regions of interest of the data sets that he have annotation for. So he have like a pre-trained network or extractor. He used actually 2 different backbones. He utilized ResNet and the VGG to extract features from rows, small rows, to make like a detection problem. And then he supplied the rest of the data for that was just labeled in an extra layers to make a whole image classification. So he started by regions of interest to train on, then he used the full image later on to train the rest of the network. But actually, it's kind of tricky here to manage like the training and learning rates and changes inside the network. So what he have done exactly is that he took the first part that was trained on rows, and he trained it on, he got like pre-trained weights from ImageNet, which is a famous data set used in computer vision competitions. And then he took just the last like layers, or the, let's say the higher order features here, and he frozen all those layers, and he learned that layer on the new rows here with kind of high learning rate. Then he took those like layers, like unfrozen those part, and still kept those layers frozen. And he learned those layers with a bit of lower learning rate. So he would make sure that the lower feature extractors are keeping the same, are not changing that much. Because for most of people who knows that in computer vision, that the basic feature extraction layers, or the first layers in any convolutional neural network, it picks up mostly the same features across different problems. So it doesn't make sense to let them change that strong when I'm adapting this to a new problem. Then when he exposed the new, the two new layers for the full image, he have done the same. He have made like an initialization for both layers with a higher learning rate. Then he started to unfrozen the rest of the network to keep it updated with the new full image features. And actually, this kind of study, it produces very good results. And actually, he targeted a harder problem, which having more classes to classify between them. So it has actually 5 different classes: the background, like a normal patch or a normal ROI or image, benign calcification, malignant calcification, benign mass, and malignant mass. And actually, this was the comparison between both both different backbones of using ResNet 50 or VGG16. So actually, by this, I finished my first part, and I'm open to receive any questions now.
Okay, thank you so much, Doctor. Now we have one question from Walid. I'm wondering, Walid, would you like to ask your question to Dr. Mustafa directly, or should I just read it? Okay. تمام أنا هقراه. The question is, wouldn't it be better to combine biomarkers obtained from proteomics, metabolomics technologies using mass spectrometry and or NMR together with mammography for better diagnosis of breast cancer, especially that FDI has approved a test name OVA1 together with an algorithm called ROMA for early diagnosis of ovarian carcinoma. The 4 proteins used in OVA1 were selected depending on biomarkers obtained by proteomic technology. دكتور حضرتك شايف السؤال؟
سمعته.
Okay, تمام.
I just heard the question. So, Walid, can you hear me, or it's hard to talk?
ايوه دكتور انا سامع حضرتك.
Okay, so أهلا بيك الأول وشكرا على السؤال يعني. So just give the audience the idea about your question. You're thinking of combining other input from different modalities, such as the bioinformatics kind of features that can be collected from the DNA. Is that correct?
ايوه تمام يا دكتور.
Okay.
خصوصا ان انا عندي بيبر بتقول ان اوريدي كمان ان هم لما عملوا كومبينيشن ما بين الماموجرافي والبروتيومكس تكنولوجي ازدادت جدا الفعاليه بتاعه الماموجرافي. فانا حبيت بس اشوف هل ده ممكن ان هو يخش، خصوصا ان بقى في التكنولوجي بتاعه الميتابولومكس على 2 بليتس، واحده الماس سبكترومتري والان ام ار سبكتروسكوبي. فدول اعتقد ممكن هم يزودوا من الحساسيه بتاعه الماموجرافي.
صحيح مظبوط. بس هي الايديا كلها في حاجه، احنا we are proposing here some actually يعني ببساطه شديده جدا تقدر تشوف عدد البيبرز اللي بتتكلم على جزء الماموجرافي as a standalone and the other, and that would give you a bit of intuition which one of them is cost effective. Do you know what I mean? يعني الفكره ان انت if you would like to get like a sequence DNA extracted and then a sequence alignment, then you do some extra analysis عشان تشوف الدي ان اي ده في ناحيه، وبعد كده بتشوف بقى التيشو تحت السبكتروسكوبي which is still under validation at the moment. It's not commercial, I believe, يعني up to my knowledge, يعني it's not completely commercial at the moment. So that would make the task of utilization of both of them مع بعض a bit tough. معاك طبعا في field بالكامل اسمه radiogenomics and radiomics and so on that would interest يعني the part that you are talking about. And there is a lot of studies that are interested of this at the moment, but I believe that most of them are research studies, and they are not commercially used. But I agree with you, of course. Utilization of other things that would make not screening anymore. It's diagnosis now using mammography.
طيب يا دكتور اشكرك جدا.
اتمنى اكون جاوبت على سؤالك يعني.
يا دكتور اشكرك يا فندم اشكرك.
اوكي دكتور ما عندناش اسئله ثانيه في السكشن ده فممكن we can proceed take more questions later on.
Okay.
Actually one question. Ali بيسأل why VGG16 is more efficient than ResNet 50.
I'm not sure يعني علي يقصد السلايد المفتوحه دلوقتي ولا حاجه ثانيه قبل كده، لان السلايد اللي قدامي بتقول ان ResNet more efficient عن VGG. And I can say why, because we are using residual connections. And I believe that residual connection is very important in any kind of network. In case of the reduction of features or loss of features across the convolution is quite strong. Because the يعني residual connections دايما kind of make sure that you are not losing information from the past. It makes the flow of the old features to the newer phases of extraction of features are quite efficient. So that's why ResNet or residual blocks in general يعني would work better than a normal convolution neural network like VGG. And actually this is confirmed here يعني من الstudy دي انه معظم الclasses accuracy هنا ال different classes is kind of higher than the VGG when it was used here.
دكتور علي بيسأل if how does AI compare to human physicians. حضرتك تحب ترد على السؤال دلوقتي ولا لسه هيجيله الانسر بعدين؟
بالظبط زي ما انت قلت يعني في جزء هنتكلم فيه قدام اللي بنكوربوريت فيه حته بقى الانترا اوبزرفابيلتي.
بيرفكت. اوكي علي الاجابه بتاعتك لسه جايه further along the line في البرزنتيشن فاستنى عليها شويه بس. اوكي ثانك يو يا دكتور ممكن نكمل دلوقتي.
شكرا. اوكي طيب احنا كده يعتبر الحمد لله we have just finished the first part, which is the screening using a mammogram, and then the next step is to use ultrasound to validate the findings of mammogram and maybe use it for to guide the biopsy. And actually this study was really nice in tackling this problem. So as you can see here on the images on the right side, those are images acquired by ultrasound. And ultrasound is like approaching with a probe to the suspected area on the breast, and then took specific images, and then then the radiologist takes some region of interest around this suspicious area. And what is needed here is to classify between the two groups of images: the top images, which is a malignant lesion images, and the low 8 images, which they are a benign kind of lesions. And in this study, they have collected kind of fair number of patient data sets, which were this number, about 5K. And those images were containing a number of automatically segmented masses. So semi-automatic segmented masses. So what they have done in this, they have used an external image processing software to annotate like those images or create masks for the regions of interest inside and even the object of interest, which has resulted in about 7K different small images from those patients. The method did comprise 4 main steps: histogram equalization to enhance the quality of the image. Then they have made what's called image cropping, like to take part of the image, not the full image. Then they have made something kind of new, written as new, but actually for me it was kind of conventional. It's called margin augmentation. And then they have utilized Google LeNet, but actually in a different manner. They have introduced some changes to Google LeNet to make it work differently. So what they have done actually, this is actually a histogram that shows the distribution of different, if you remember, we talked in the beginning about BIRADS, like the categorization of patients. So it's very important to have a fair like split inside our data set. So those are different, the 5 categories that we have. If you remember, one was the normal. And if you remember that those were patients, so we don't have any normal cases here. And our task is to classify between normal, between benign lesion and malignant lesion. And benign, they are actually composed of two different BIRADS, 2 and 3. and malignant, they were 4 and 5. Actually, what they have done exactly, if you remember the thing of I told you about the margin augmentation, was kind of new for me. What they have done, they created from each image 3 different, or actually more kind of different scales, but with a different tweak. That they have proposed that their metric to define the magnification here, or let's say the how close is the object of interest. They have said that they're going to measure the distance from the object of interest to both vertical boundaries. So they're going to measure this and this, and they're going to make this distance for the same image with 3 or more kind of margins. They created like 70 pixels from the right and left, and another one with 50 pixels from right and left, and another one with 30 pixels. And then they have rescaled the 3 images to the same size, which is 256 by 256, which actually lead to different scales, basically. But actually, they need to come up with number to define this kind of scale, not like 1 or 2 or 1x or 2x and so on. But actually, what they have done here, they were having initially, like for just the benign samples, they have about 4K, and they have boosted that number by augmentation to almost 500,000 samples with an multiplication factor of about 150. And that's kind of huge. That took a lot of time from them, and they trained actually their model on different machines and collected their models in a specific way. And they used then the Google LeanNet. But actually, what they have done, they have removed those auxiliary classifiers. And basically, those auxiliary classifiers have been proposed by Google LeanNet team, or I mean, study team, to solve the problem of the vanishing gradients. So since the network is quite deep and long, so it's very expected to have like almost 0 gradients of weights, which means that we need like in the middle some classifier to calculate the loss from, and get the whole loss as a summation from the loss from here, the final classifier, and the losses from the auxiliary classifiers. But actually, they have removed it, and they didn't complain about it in their results. So it seems that for this specific problem, maybe because the object of interest, it doesn't look different like the other data set that was used in the original Google LeanNet, like what was the name of that data set? The ImageNet. So that maybe that's why it works with them, but I'm not sure if it would work with other problems or not. Actually, this is the ROC curve for actually 4 different algorithms. They have used the Google LeanNet on a data set that's the margin is 0, and another one was the margin was 180, like a different scale, and an SVM and an ensemble between that 1 and 1, like 180 and 0. And it seems that the ensemble model that combines actually the 2, 0 and 180 is kind of performing better, which is the red one here. It has a bigger area. So when this area is getting bigger, that means that we have a better performance. Also, one of the tricks that we usually use using the ROC curve, that we can pick up the best threshold. So, you know, any classifier produced like a float value between 0 and 1 to give you a probability of foreground or background or object or no object. And actually, when you would like to calculate such curve, you need to keep the final probability or the output probability as it is. And then using this curve, you can pick up like the best threshold that would increase maybe the true positive rate, the true positive, to reduce the false positive or the false negative accordingly. Okay, this is the study that was Ali speaking about, I guess. And actually, this study is done by just physicians. There were no AI engineers in this research. What they have done, they used a software called Cognex VD Suite. It is a Swiss company that made this software. And that medical team, what they have done, they have collected 3 different experienced physicians. Like one was very experienced, the second one was like 2 years experience, and the third one was a medical student that was trained during that time of the study. And what they have done, they have trained each one of them, and they calculated the time for the training, and even the time that the doctor was deciding on each new image. In our language, in neural networks, it's the inference time. And as you can see here, since they were doctors and they don't know that much about deep learning, they were just calling it artificial neural network training and test. So there were no specific backbone or specific architecture was defined in this study. And what they have done, or what was their findings, that the neural network was kind of faster than the medical student in training, and the readout time or the inference time was that, as you can see it here. So the experienced doctor took about 8 seconds or 9 seconds. The medical student took about 8 seconds in readout time, and the neural network took almost 0.02 seconds per image. And that table on the bottom actually describes the agreement between readers. So as you can see, it's kind of a tough problem. The agreement between them, actually, this is like a correlation coefficient. So when this number gets almost close to 1, that means that people are agreeing, and when it goes to 0, that means that there's no agreement. And if it went to negative, that means that there's a reverse kind of agreement. So I say 1, and anybody else would say maybe no. So as you can see here, that between reader 1 and 2, the most 2 experienced, the agreement between them was quite high. And actually, the neural network was quite close to the second reader here. Like those are the highest number of agreements. And it was not agreeing with the medical student that much. So it seems that the neural network compromise between the knowledges coming from different sources, and also it goes close to the one with the middle experienced, or the, let's say, the mainstream knowledge in our data. So actually, by this, we have finished the second part, which is the utilization of ultrasound, and actually we can have some time for our questions again.
Great. هاجر تحبي تبتدي الكويشن بتاعك؟
Yes, I can go. أنا بس كان يعني كنت شايفة إن الترند في يعني في literature اللي حضرتك يعني اتكلمت عنه is to usually use deep neural networks زي جوجل ونات وريزنات. و although إن أنا شايفة إن الميديكال images، يعني أنا ما اشتغلتش في medical data قبل كده، بس visually يعني شايفة الميديكال images they are way less rich in features عامة. يعني هما ما فيهمش features كفاية تخليني أستخدم deep neural networks that are composed of 50 layers compared to problems تانية مثلا زي autonomous cores أو الداتا اللي بتيجي من RGB cameras يعني. فهل هو في سبب for using deep neural networks where shallow neural networks يعني أو like less deep networks عامة used في البروبلم دي و are they still effective if they are used ولا لا؟
Very good question and maybe hard to answer, but يعني I will do my best يعني. مبدئيا when most of people believe that when the problem gets harder يعني المشكلة بتيجي بتبقى أصعب يعني لا زود layers صعب النتورك كبرها أكتر عشان detect more features. بس زي ما أنت قلتي بالظبط there is not enough features في images عشان نقدر extract النولج اللي نقول بيها دي class 1 ولا class 2 أو class 3. تمام؟ وبالتالي الناس بتلجأ دايما، وده proven انه bigger architectures produce better results. But actually the small architectures or maybe shallow networks, they are producing almost close results, but actually when you are increasing layers, you are adding a bit of accuracy more and you are getting more specific. And luckily in most of applications you are increasing this kind of extra layers, you are not facing such a problem like overfitting that much. I mean, it's still generalizable problem if you have enough data. But if you don't have enough data, I believe that you would go with handcrafted features and shallow networks. This is my belief at the moment. But yeah, all of these are let's say I'm just exploiting another يعني maybe the enough experience is less everywhere because the data is still not annotated in a proper way. زي ما علي مثلا قال لنا من شويه حته الافكت بتاع different physician outcomes or physician classifications or categorization.
Okay. Thank you.
طب I have a kind of a follow-up question على الكويشن بتاع هاجر. دكتور، هو دلوقتي في اليوز كيس حضرتك عرضتها هم basically بياخدوا زي ما هاجر قالت pre-trained models على pre-trained models تبقى trained على ImageNet مثلا، وهي حاجة generic يعتبر. فهل هم بيعملوا كده علشان سبب معين، ولا because they just think it will work ف they try it and it works فخلاص؟ والحاجة التانية مثلا في حتة الكيس ستادي بتاعت they use the augmentation to significantly augment their data set by doing this resizing. برضو أنا حسيت شوية was it founded on anything specific، ولا هم جربوا الأول اشتغلت فكملوا بس؟ وعندنا أسئلة تانية.
تمام، خليني بس افتكر اول سؤال الاول عشان
يعني the use of kind of generic architectures trained on general data sets.
فاهم قصدك. هي الفكره كلها انه هقول لك يعني my personal experience we are sometimes dealing with huge images. For example, in mammography images it's quite a huge image that would goes from الريزولوشن بتاعتها من 5000 4000 باي 4000 ممكن توصل ل 6 3 and so on يعني. ف we are enforced kind of to يعني down sample such an images to an extent حاجه تبقى 1000 في 1000 مثلا. لو انا هفيد حاجه زي كده للنتورك with maybe huge number of samples that I have, I would take ages to just finish single epoch, like to cover all samples that I have. So it's preferred ان احنا نبتدي pre-trained models that would ready enough, or خلينا نقول ان الويتس بتاعت initial layers are quite stable, reach a specific or mature enough. So when I run it for a small number of epochs on a new data set or my own data set, I wouldn't take that time. I wouldn't take that much of time. فعشان كده بيبقى في نيد ان احنا نستخدم الايه البري ترين مودلز اللي متعلمه على حاجات اصلا كمبيوتر فيجن مش ميديكال ايمجز. السؤال الثاني ممكن بس نفتكره سوا عشان
الكيس دي الاوجمنتيشن.
الاوجمنتيشن. خلينا نقول مع بعض ان الموضوع كان جاي من باك جراوند اوف يعني فيزيشن، انه او الراجل خلينا نقول الاوبريتور بتاع الالتراساوند ماشين وهو بيحرك البروب ذات نفسه. There are some settings that would produce different scales of the tumor. So the same tumor with different settings that would get bigger and smaller. So that's why he was doing the same, trying to mimic the same kind of behavior in his augmentation. For example, in mammography, we can flip the images, like the right to be left pressed and the left would be right pressed. This is the kind of augmentation we use. But to do a rotation to make the breast looking like, instead of vertical, like horizontal, that would make a lot of sense. So most of our augmentation should be making sense and fitting the application that we have. على سبيل المثال مثلا ما ينفعش استخدم ميكس اب اوجمنتيشن، ما ينفعش احط تو ايمجز فوق بعض واستخدمهم يعني، لان ساعتها الليبل مش عارف اجمعها يعني، دي different category بس.
Okay, thank you so much, Doctor. طيب more questions. علي بيسأل in this case can contrast limited adaptive histogram equalization be more effective than histogram equalization?
في الابلكيشن ده ما اظنش.
اتفضل.
في الابلكيشن ده اكيد طبعا. الابلكيشن ده اكيد، لان مش هتبقى patient specific، هتبقى data set specific.
Okay. طيب علي عنده another question. What about using common models such as random forest? يعني حضرتك you presented deep learning approaches. What about the more classical approaches?
Yeah, most of classical approaches require ان احنا extract features بنفسنا. يعني مثلا في الراديومكس اللي هو اللي كان بيتكلم عليه الباشمهندس في الاول، we need to extract features from the images and they have this يعني supplementary مثلا one of the famous papers يعني اللي بتشتغل في الراديومكس عندهم supplementary file فيه حوالي 70 او 80 feature extractor. بيقولوا ان دول الفيتشر اكستراكتورز اللي بيشتغلوا كويس في الكيس ديت. Sometimes it works, but في some gray zone cases that we cannot deal with, and that's why we're seeking the help of deep learning. Usually, the need for deep learning comes from those cases which are lying in this gray zone.
Okay, so هم تقريبا يعني ممكن نقول ان classical approaches kind of جابوا اخرهم، فعشان كده احنا بنحاول نشوف حاجه more advanced to give us the remaining accuracy that we need.
عندنا data، عندنا feature، عندنا better feature extractor or feature descriptors، عندنا machines، ف why not يعني.
Okay. Good reason as any. طيب انجي عندها question. What do you think of quality microwave imaging in breast cancer? Can they add to screening diagnosis?
لا انا ما اعرفهاش، انا ما اعرفش الموداليتي دي، فممكن يعني تتدخل تدخل
ممكن
معانا وتقول لنا ايه بالظبط دوت.
انجي تحبي تشرحي لنا اكتر هي ايه؟
انا بس يعني مايكرويف ايميجينج يعني تكنيك يعني ماموجرام والالترا ساوند يعني كلاسيكال في الايميجينج but now microwave imaging is coming يعني as a tool to also for screening diagnosis. فكنت يعني بسأل دكتور محمد اذا كان اتعرض للكواليتي بتاعت الايمجز اللي طالعه من المايكرويف and how you think of it يعني.
ده حقيقي يعني شكرا على سؤالك طبعا، بس انا يعني النولج بتاعتي يعني ما تعرضتش للنقطه دي قبل كده خالص.
اوكي.
وما تعرضتش للمايكرويف ايمجنج قبل كده خالص.
Yeah, it's emerging. It's emerging يعني now to use microwave instead of mammogram والتراساوند على اساس تكلفه، وكمان يعني مش زي السي تي يعني ما فيش ionization effect. فالوقتي there is some trend to use it يعني for screening or for monitoring after vasectomy يعني. فأنا بس كنت حضرتك قلت إن حضرتك اشتغلت فترة في medical place، كنت عايز أعرف هل دي assess يعني microwave imaging أو what do you think of the quality of the images coming يعني.
تمام. لا هو بصراحه لا يعني انا ما شفتش ستاديز بتتكلم عن الموضوع دوت. ما تعرضتش ليها بحكم الابلكيشن لان انا بتواصل مع الدكاتره الى حد ما. فالحاجات الثانيه اللي emerging حاليا حته الكونتراست ماموجرام، وده they can see actually they can differentiate between the normal and abnormal in an easier manner، لانه التيومرز they can suck the contrast agent بشكل عنيف يعني. هو quite obvious يعني. بس انا فاهم حته الميكرويف عشان it's there is no hazard صح كده. وبالتالي فهي حاجه سيف ومفهوم الكلام ده for screening. بس انا حقيقي لا ما شفتش اي studies بتيوتلايز الماشين ليرنينج للشغل ده.
طب دي فرصه بقى ان انا اتكلم مع حضرتك يعني اكتر، احنا بنشتغل في التوبيك ده، ففرصه ممكن اخد ايميل حضرتك او ابعت حضرتك ميل. انا دكتور انجي قدامك من هندسه عين شمس اي سي اي. فاحنا كنا يعني شغالين هنشتغل مايكرويف ايميجينج او هنشتغل احنا اللي نعمل مايكرويف، فكنا عايزين نتكلم مع حضرتك اكتر برضه. ممكن نشوف اذا كان ممكن نمرج يعني الايمجز اللي هتيجي من عندنا، ونشوف اذا كان الكواليتي بتاعتها يعني it can be compared with what coming from mammogram. It will be nice يعني.
اوكي
دكتور.
الايميل اللي انا هكتبه لحضرتك دلوقتي وهيبقى موجود في
خلاص ممكن نتواصل بعد السيشن ان شاء الله يا دكتور.
اكيد ان شاء الله.
تمام.
شكرا جدا لسؤالك.
ثانك يو دكتور انجي. عندنا سؤال من عمر. سوري انا اوكي سو عمر بيسأل is interpretability important for using these models for commercial use? A very important question.
صراحة interpretability لو فهمت السؤال صح يعني عمر يقصد interpretability of the intermediate layers يعني الفيتشر extraction ولا ايه بالظبط؟ انا حابب افهم السؤال اكتر.
عمر لو تحب تكلاريفاي، بس يعني لو انا هحاول اكلاريفاي انه حاليا احنا بنتكلم على deep learning models، والمعروف ان هم black box models او approaches. فكون ان انا مش فاهم بالظبط ال decision they get decided upon which features exactly with weights قد ايه وكده. هل ده بيأثر على the integrity of the solution و the potential of it becoming a commercial model. بس عمر لو حابب تقول لنا clarification please go ahead.
لا تمام يعني
اوكي تمام.
شكرا يا عمر على سؤالك، يعني سؤال ممتاز جدا. اكيد لو قدرنا نفهم الايمجز اللي طالعه او الفيتشرز الانترنال فيتشرز what they are pointing at in the image ده يعني ده يبقى شيء عظيم. احنا احيانا بنستخدم السالينسي مابس عشان نشو what is the part of the image that has voted for this specific class. Sometimes it works, sometimes not. But actually يعني خلينا نقول انه was work on showing such an intermediate output or from the network that would add credibility اكيد للريزلت بتاعتنا للدكاتره. بس خلينا نقول برضه ان الدكاتره they are amazed by the results and the performance of the results, and that's why they are trying to getting يعني trusting in technology a bit يعني حاليا. ف and actually and they are trying to contribute كمان. فده يعتبر شيء كويس so far. Actually one of the other things that would convince them يعني in a better way is to show them that the network or the modeling step is kind of compromising between the different qualities from different physicians. ودي حاجه بالنسبه لهم when it was proven يعني الناس منهم طبعا اللي aware بالتكنولوجي حاليا it makes them kind of happy يعني with their performance. بس وفي الاول وفي الاخر برضه احنا يعني the message should be that we are not replacing, we are just giving a hand, we are just showing where is the problem and then you can continue. We are not writing reports, final reports, we are not going to be robots and or doctor robots يعني. فيعني المسج المفروض تبقى واضحه يعني.
ثانك يو يا دكتور. طيب علي هتحب تسأل سريعا الأسئلة بتاعتك ولا نسيبها للآخر؟ اوكي انا
سامعني كده صوتي واضح؟
لا في ايكو قوي جدا.
كده احسن؟ كده متهيألي واضح
كده كويس.
طيب تمام. انا بس السؤال الاولاني، احنا ليه ما نستعملش مثلا الالترا ساوند الدوبلرز عشان نشوف الفلو بتاع البلد ونديترمن من الفاسكولاريتي اذا كان التيومر ده بناين ولا مالجنت؟ فهل ده ممكن يبقى فيه حاجه كمان with the help of AI agents ان هو يبقى more accurate ونسيف الومن بقى ان احنا نعمل الماموجرام بالاكسبوجر بتاع الراديشن اللي بيتعرضوا له والكلام ده كله؟
جميل سؤال جميل. الايديا برضه في يعني انت عارف فكره الماموجرام ليه الدكاتره بتحطه قبل الالترا ساوند؟ لانه it's a full pressed view that you can see collectively where is the problem or where is the suspicious areas. ولكن الالترا ساوند it would require from the radiologist to move across the whole breast that would take a lot of time. يعني لما تبقى هي عارفه مثلا على سبيل المثال خليني مثلا الصوره ديت احنا هنا في suspicious area صح كده؟ بريفير للالترا ساوند بقول له والله يعني باي ذا واي الدكاتره بيسموا يعني بيقسموا البريست لاجزاء وبيسموا كل جزء باسم يعني. فباين هنا انه ده الابر بارت يعني لو دي الابنورماليتي فموجوده في الابر بارت اوف ذا بريست تمام. ولو بصينا هنا في الفيو الثاني هنلاقيها اتس ا بيت كلوز تو ذا ايه تو ذا ميدل اوف ذا بريست بالطول. فلما اروح اقول له والله يعني روح بص كده in the middle of the breast you are looking perpendicular to the breast and go a bit higher اللي هي الحته ديت يعني يطلع فوق شويه، ده تقريبا المكان بتاع السسبشن او المكان اللي احنا قلقانين منه. ابتدي ابص بالبروب بتاع الالتراساوند. لكن لو اخذ البروب وابتدي يتحرك على كل الريجنز ديت that would take a lot of time that doesn't make him effective لانه when you are looking at a specific location you're going to take you're going to spend time and effort to concentrate. Actually it takes some time to make a proper image يعني من الالتراساوند. لكن لما تبتدي تتحرك في كل حته يعني that kind of scanning that would require a lot of time and would reduce the sensitivity of detection of any abnormality. فالultrasound to be used as a screening, I prefer it's not going to be like that at the moment except if there is this kind of 3D ultrasound. طبعا انت قلت دوبلر، فدوبلر تقصد بيه غالبا ال يعني الداينامكس of blood flow inside the breast. بس اعتقد الداينامكس بتاعت البلاد فلو جوه مش قويه قوي زي البيج ارتريز اللي موجوده في جسمنا الثانيه زي الاورتا والاذر ارتريز اللي موجوده في الثوركس يعني. دي تتشاف بدوبلر ويبان الكالر فلو، لكن في الحتت دي اعتقد يعني if you're gonna use micro يعني micro ultrasound او حاجه يعني ultrasound that would go for a very small field of view.
طب دكتور عطار بالنسبه للام ار اي مثلا هل في شغل اي اي اتعمل على الموداليتي بتاعت
في كتير بس للاسف الشديد يعني هاجر قالوا لي ما تطولش بس
بليز خلينا move on with the rest of the presentation عشان برضه دكتور عطار ما نعطلوش and لو عندنا وقت في الاخر ممكن ناخد questions اكتر شويه.
sure
thank you.
شكرا يا علي، شكرا جدا. طيب النكست ستيب احنا خلاص عرفنا دلوقتي الالترا ساوند فين المشكله اللي موجوده واتاكدنا ان في مشكله، بس عايزين نتاكد بقى هي فعلا بناين ولا مالجنت، ولو مالجنت التوحش بتاع المالجنسي ده قد ايه. فبنحتاج ناخد الايه البايوبسي. البايوبسي بتتاخد زي ما انتم شايفين كايند البايوبسي نيدل دي النيدل بتاعتها تبقى كبيره شويه عشان تقدر تسحب شويه خلايا او انسجه يعني عن طريق الايه البايوبسي نيدل ديت. اللي بيحصل بعد كده انه السامبل دي بتروح تتقسم على حاجه اسمها تيشو بلوكس، بعد كده بتتحط في حاجه اسمها سلايدز بتعملها ستيننج او يعني تحط عليها زي داي ماتيريال عشان نقدر نشوفها باللون البنفسجي اللطيف اللي هوريه لكم كمان شويه. بعد كده بتتحط في اري كده اوف سلايدز، بعد كده بنبتدي نشوفها تحت الميكروسكوب. فالمفروض الباثولوجيست او الراجل المسؤول اللي هو بيبتدي يبص على الميكروسكوب ده مانيولي، بيبتدي يبص ويشوف الفايندنجز بتاعته ويبتدي يديفاين البروبلم فين في السيل ديستريبيوشن اللي موجود قدامه. بس واقعيا اكشلي الميكروسكوب ده كان بريديوس some digital images and here our role can come. يعني ال AI can help في البارت دوت. So actually our task is to take those kind of images and classify them to malignant or benign. We don't need to say normal لانه خلاص ما بقاش في normal. احنا دلوقتي يعني عندنا problem مش عارفين هي benign ولا malignant ولا malignant. If you consider it here يعني في هنا حته كده، الحته الصغيره دي magnified الصوره الكبيره. واكشلي this kind of tissue يعني distribution اللي احنا شايفينه قدامنا دوت، ده بيكورسبوند لايه؟ لشويه كانسر سيلز موجوده في الليفر او في الكبد يعني. If we extended this للبريست كانسر، دي الكايند اوف ايمجز اللي بنشوفها، ودي اول ستادي احنا بنتكلم عنها باي بايرام اوغلو يعني and his team that was published in ICBR. What he have done in this problem, he took the images that needs to be classified to benign or malignant, and as you can see here that we have different scales. So on each scale you can see different information, different kind of level of features. But actually يعني المكان اللي احنا بندور عليه، المكان اللي بندور على البروبلم فيه ممكن يكون حته صغيره جدا في الصوره اللي هي 40 اكس، بس لو احنا عملنا الزوم الصح هنقدر نشوف اللي هي عند 400 اكس. وبالتالي هو اقترح ابروتش لطيف جدا. عمل الاوجمنتيشن بتاعه، وبعد ما عمل الاوجمنتيشن ابتدى يجنريت 4 different piles of labels عند different عند different scales، عند 40 اكس، 100، 200، 400 اكس. وبعد كده عمل زي كروب روتيشن فليب كايند اوف اوجمنتيشن وجهز التريننج سيت بتاعته. بس وابتدى اكستراكت فيتشرز بسي ان ان عاديه خالص. وهقول هنتكلم على التو تايبس بقى اللي استخدمهم بعد كده، وهو بيميك سنس اوف ذا اكستراكتد فيتشرز. الجزء دوت بيبريزنت الايه الدنس لايرز، واكشلي في الحته دي هو عمل تو kind of models. They are not working together but he have just made it for the sake of this study. عمل two classifiers، واحد منهم single task model والثاني كان multi task model. السنجل تاسك موديل كان وظيفته بس يقول دي بناين ولا مالجنت، والمالتي تاسك موديل كانت وظيفته تقول بناين ولا مالجنت، دي حاجه. والحاجه الثانيه يقول لي هو الكلاسيفاير يبتدي يتعرف على الصوره دي، يشوفها هي جايه اصلا من انه زوم او خلينا نقول انه سكيل او انه ماجنيفيكيشن، جاي من 40 اكس ولا جاي من 100 ولا 200 ولا 400. تمام. طب فايده حاجه زي كده ايه؟ فايدتها ان هو هي كان اد يعني لو هو شايف حاجات عند 40 اكس فاكشلي التراست وورثي بتاعت السكيل دوت would be less would be higher in case of having more samples that would vote for the same magnification. ف في عجاله يعني التو كلاسيفايرز اللي استخدموا اللي هو السنجل تاسك موديل ده كان عنده سوفت ماكس كلاسيفاير واحد عشان يقول بناين ولا مالجنت، والمالتي تاسك موديل كان الداتا تو بي فيدد يعني ثرو convolutional neural network، وفي الاخر تو فولي كونكتد، مش في الاخر ان ذا ميدل في تو فولي كونكتد، وفي الاخر في تو في برانشين، تو برانشز، واحد رايح لفولي كونكتد عشان يديسايد للبناين والمالجنت كلاسيفاير، والثاني كان للسكيل. واكشلي الاوفرول لوس بتاعت الكلاسيفاير التحتاني ده بالخصوص كانت السمشن بتاعت الايه التو لوسز اللي جايين من التو كلاسيفايرز، دي الايكويشن اللي بتكمبرايز الريليشن شيب ديت بتاعت الاوفرول لوس. واكشلي الدبليو بي ام اللي هي الويت بتاع اللوس بناين مالجنت او الويت بتاع الماجنيفيكيشن كانوا الاثنين بيساووا بعض في الاكسبيرمنتس اللي هو نفذها. لما غيرها لا ما فيش ميجر تشينجز يعني، فهو كابت ايه ويت سيميلر. الريزلتس كانت لطيفه جدا لانه لما عمل فيدنج للتو نتوركس بسنجل يعني عندنا فيه هنا تو مودز. في مود كان دخل فيه الداتا بتاعت ال 40 اكس بس لوحدها وعمل كلاسيفيكيشن، وفي مود ثاني مثلا دخل الفور ماجنيفيكيشنز مع بعض وعمل تيستنج لكل الداتا. فلما استخدم ال 40 بس وعمل تيستنج لل 40 دي الارقام اللي كانت طالعه، ولما عمل ترين بال 100 وتست ال 100 دي الارقام اللي كانت طالعه. however لما كل الداتا بتاعته الفور ماجنيفيكيشنز يعني actually it performed better في حاله ال 40 اكس وال 100 اكس اكتر من الايه من الماجنيفيكيشن سبيسيفيك مودلز يعني. and actually that would promote اليوتيلايزيشن. دايما لو احنا عندنا different data sets او بنجنريت بنحاول نوجمنت وبنكريت مالتيبل سكيلز، ما نعملش سكيل سبيسيفيك، نحاول نكومباين كل الحاجات، يبقى الموضوع ايه، كل السكيلز تبقى مع بعضها في نفس الداتا سيت يعني. احنا كده يعتبر خلصنا الوان ستادي اكزامبل، اكشلي الوان ستادي اكزامبل بتاعت البايوبسي. اخر حاجه عندنا I can jump over to this صح كده ولا ايه رايكم؟
please يا دكتور عشان we can go on to the next part.
اوكي طيب ماشي. اخر جزء عندنا احنا خلاص خلصنا كل حاجه، فاضل ان احنا بقى ايه نبلان التريتمنت. انا هبيك اب بس واحده منهم، الراديو ثيرابي. والراديو ثيرابي ببساطه احنا emit some gamma radiation and or X-ray radiation depends on the modality يعني to the affected object of interest. يعني في تيومر معين احنا هنبعت عليه الاشعاع ده بحيث يكل الايه الكانسر سيلز ديت. طيب الفكره كلها ان انا مش هينفع ارمي الاشعه دي على البيشنت وهو نايم. يعني الماشين اللي انتوا شايفينها قدامكم دي اسمها لينير اكسلريتور او لينك، بيمت الراديشن من فوق على البيشنت. فانا مش هينفع اعرض جسمه كله للخطر، مش هينفع ابعت الراديشن على كل حته في جسمه، خاصه ان في اورجنز ثانيه اوف انترست ومهمه جدا زي القلب، زي الاذر اورجنز اللي موجود زي اللانجز، وانا مش عايز احرقها بالراديشن دوت. فوات actually they use in such modality حاجه اسمها ايه مالتي ليف كوليميتر سيستم. فكرته كلها ان احنا عندنا شويه رودز اللي انتوا شايفينها ديت عباره عن مجموعه كذا قضيب من الرصاص يعني او الليد ليفز يعني. والليد ليفز دي بتتحرك في الاتجاهات ديت، في الاتجاه او في الدايركشن دوت، بتروح وتقفل بحيث ان هم لو كلهم انضموا على بعض هيقفلوا السين خالص. فلما الراديشن ينزل وهم مقفولين مفيش حاجه هتعدي، ولو اتفتحوا باشكال مختلفه دي كان جنريت بروفايل او بروجكشن تحت كده اهوت that would correspond to the geometry of the tumor that I have. ففي الحاله دي لو القلب مثلا كان موجود هنا اهوت والتيومر كان موجود هنا اهوت، فانا هافكت التيومر بس من غير ما افكت الايه الهارت مثلا. فالموفمنت بتاعت الحاجه ديت بتبقى مهمه جدا بالنسبه لنا. وده الشكل كده لو البيشنت نايم بيبقى شايف الايه المالتي ليف كولومتر من تحت بالمنظر ده، فالاشعاع بيبقى نازل عامل الشكل اللي هو البروفايل اللي قدامكم ده. معنى كده ان انا محتاج اكستراكت شكل التيومر او خلينا نقول الاورجن الافكت باي كانسر بشكل 3 دي صح عشان اقدر ابلان الايه التريتمنت بتاعتي بشكل كويس. عشان كده بنحتاج نعمل سيجمنتيشن، ودي الستادي يعني ما فيش خلاص، دي اخر ستادي هنتكلم عنها النهارده اللي هي المالتي اورجن سيجمنتيشن في السي تي ايمجز. والسي تي ايمجز اضطرينا نستخدمها اخيرا عشان بتبروفايد 3 دي انفورميشن اباوت دي دي فوليومز. الناس اللي اوير بالسيجمنتيشن تشالنجز في الميديكال فيلد عندنا فيري سكسسفول موديل اسمه يونت. هو انكودر ديكودر لايك اركيتكتشر، بينكود الفيتشرز لغايه لما تبقى kind of flattened features، بعد كده بيبتدي يعمل لها تاني ايه expansion او decoding عشان يجنريت the same size of the image that was fed in the beginning عليها الماسك او عليها الاوتبوت سيجمنتيشن. actually الناس هنا عملوا two extensions لطاف. اولهم ان هم استخدموا 3 دي يونت، فهم they actually feeding the network with 3 D volume and actually embedded the residual blocks in the encoding path بحيث they don't lose information when they are خلينا نقول ايه بيلوزوا السبيشال اسبكت بشكل كبير and when they are expanding they are using conventional convolutional blocks and there is a lot of intermediate escape connections عشان to preserve the knowledge ما بين الانكودنج والديكودنج paths. فاكشلي دول two contributions اللي هم عملوهم، واكشلي this is the results that they have. يعني عملوا actually عملوا 3 ستاديز، استخدموا النيتيف يونت واستخدموا السنجل اورجن بيب نت. والسنجل اورجن هنا دي فيدد جاست انوتيشنز للبريستس، التو بريست لوحدهم والهارت لوحده. والمالتي اورجن بيب نت كانت نتورك متعلمه للثلاثه اورجنز مع بعض. وسربرايزنجلي المالتي اورجن بيب نت actually perform better than the single organ and the unit for the 3 structures يعني. And that promote يعني in case ان احنا عندنا multi organ segmentation problem, it's better to go for a multi organ modeling instead of single organ modeling. التو images او التو arrays of images الموجودين هنا هو دول حاجه بنسميها توبوجرام، بيستخدموها بس وقت البلاننج، ف there is no need يعني for ايه to talk about them at the moment. بس اعتقد يعني just I'm gonna briefly jump over this. يعني we have finished most of our management algorithm اللي احنا اتكلمنا عليه من البدايه. و if we go to the conclusions actually there is 4 main conclusions that we have to يعني address. اولهم ان احنا لازم نبقى عارفين الناتش بتاعت الميديكال داتا. It's critically important عشان نقدر يعني نستخدم فيتنج داتا سبليت صح، نقدر نعمل داتا اوجمنتيشن بشكل صحيح، ونقدر نبيك اب الايه السيتابل داتا ليرنينج ديب ليرنينج اركتكتشر. الحاجه الثانيه انه لو الفيزيشن بريدكتيف اكيورسي از هاي بس الهاند كرافت فيتشرز بتاعتنا بتشتغل كويس، I believe that we have to go for a convolutional neural network. لانه it seems ان الدكتور قادر يشوف الفيتشرز بعينه بس he cannot describe by hand or by transferring his knowledge to an engineer who can do this job. بس actually it will describe unexplained features better في حاله الconvolutional neural network. ثالث نقطة ودي اتكلمنا عليها في خلال المحاضرة أو خلال التوك، يعني إنه الانتر أو الانتر observability هي حاجة important بالنسبة لنا قبل ما نشتغل على البروبلم، عشان نبقى عارفين البروبلم هي صعبة قد إيه. ما اظلمش نفسي واظلم النتورك اللي في إيدي يعني. آخر حاجة المالتي أورجان segmentation usually it's performed better than the single organ segmentation يعني أو modeling، لأن الفول image context there's يعني الموديل بيبقى full image context aware يعني، خاصة لو الأورجنز قريبة من بعضها. بس اعتقد باي ذس يعني I finished my presentation. حابب اشكر تاني الشباب واشكركم جميعا على الوقت اللي انتم فتحتوه لي انا عشان اتكلم عن التوبيك بتاعي. نقطة أخيرة قبل ما أقفل، الناس اللي حابة تعمل ريسيرش في التوبيك دوت there is plenty of available data sets موجودة على ويب سايت اسمه The Cancer Imaging Archive or TCIA. I just took a screenshot for only breast cancer related data sets. You can see that there are a lot, but يعني ربنا يوفقكم بقى في الداونلود بتاعها. It's quite challenging. وشكرا لكم جميعا. This is my email يعني for anyone who would like to contact me later.
Thank you so much, Doctor. And actually, I have one final question. It's related to the conclusions. حضرتك كنت you mentioned الانتر والانترا observer variability ان احنا بنستخدمها عشان نحدد how hard is the problem. طب انا اصلا ازاي بتعامل معاها وانا ببيلد الداتا سيت؟
من ناحيه الكولكشن يعني
بالظبط، يعني هو لو انا عندي داتا سيت عندي مثلا ايمج معينه فيها هاي انتر او انترا observer variability والمفروض ان هي it's labeled by professional physicians. طب انا لو دي الكيس انا هعمل ايه بقى؟
طيب تقصدي في البريبريشن بتاعت الكولكشن ولا
بالظبط.
بعد كده هو ماشي؟ اللي بيحصل في البدايه خالص ان I have made this actually twice يعني during my PhD يعني. بجيب الدكاتره طبعا بعد ما نتفق معاهم، الدكاتره وقتهم ثمين جدا بلمهم وبعرض يعني بعرض عليهم الداتا بشكل راندوم، يعني ما ينفعش لو هم قاعدين في نفس الروم اوري الداتا بتاعت يعني اللي هم يعملوا لها annotation او labeling بنفس الترتيب، لان هم they can look at their computers بشكل لا ارادي and they can maybe be affected by their colleague مثلا working or something like that يعني. لازم برضو اختار نفس الوقت اللي بلم فيه الداتا منهم، يكون الصبح بدري عشان يبقوا مركزين جدا. بعد ما باخد الداتا دي منهم ببتدي اميجر الفاريشنز اللي ما بينهم عن طريق كذا متريك. I can use for segmentation the surface distance between the objects of interest. I can use the other metrics such as the IOU or the dice coefficient. ولو استخدم labeling I can use the conventional accuracy measurements to just measure the differences ما بينهم. فالagreement metrics are a lot. I can use the same one that I assess the accuracy بتاعت الكلاسيفاير اني اقارن ما بينهم الاثنين ما بين الريترز وبعض يعني. طب لو عندي بقى multiple raters و I found some variation ما بينهم there is some step of filtering I have to perform عن طريق ان انا اشوف الحاجات اللي كان فيها higher agreement and I can pick this as the first data set I'm gonna impose to my neural network. Then I can branch my network to maybe behave or mimic each one of them if I'm doing like an initial trial or an initial experiment. لكن ان اضم كل الداتا مره واحده بتاعتهم اعتقد ده هيبقى فيه ظلم للنتورك.
تمام. انا مش متخيله ان هو يعني لو في اصلا very high variability النتورك هتعمل ايه؟ ما هي هتحاول هتمامك ال variability دي which is not good في الاخر.
It will try to compromise between them. بس actually في نقطه مهمه انه لو انا خدت ال common cases اللي هم they are correctly they were agreeing all together عليها انا كده بسهل التاسك على النتورك، بخليها تعرف features مهمه فعلا و it's not a noisy features خلينا نقول.
Great, thank you doctor. We have إيمان. ممكن إيمان تقولي السؤال بتاعك؟
شكرا دكتور على السلايدز اللي حضرتك قلتها، البرزنتيشن رائعه جدا. بس انا عندي سؤال دلوقتي، انا بعمل بروجكتس مع نفسي او كورسز خاصه بالاي اي فور ميديكال باخدها اونلاين، بس عايزه اجيت بيتر في المجال. اعمل ايه؟ يعني ايه الاكتر من ان انا ابلاي الماشين ليرنينج والديب ليرنينج الجوريزمز على على البروجكتس اللي قدامي المشهوره، اللي هي مثلا just كانسر او الليبلز اللي موجوده فيه،
هو
او سكان، الحاجات المشهوره دي اللي احنا بنعملها. ايه بقى التاني اللي ممكن اعمله؟
اوكي، يعني هقول لك على حاجه. انت مثلا شايفه التي سي اي اي مثلا على سبيل المثال، there's several data sets for each kind of organ. يعني هم انا مرتبهم هنا بالاورجن، فانا شايف الداتا سيتس الخاصه بكل اورجن. الفكره انه انا كمان I can look after other organs or actually احنا يعني بيبقى في يعني usually it comes from papers. يعني بنفتح مثلا على جوجل سكولر على حسب التوبيك اوف انترست، يعني وتبتدي تشوف الليتست بيبر. فانا بالنسبه لي مثلا بحب دايما يعني بنصح حتى الشباب اللي معايا ان هم if they would like to investigate a specific work they have to go for the most maybe cited paper and they have to or يعني they try to generate at least the baseline results that they saw in this paper, at least reproduce the same thing that you see in a paper. لان usually you're not going to produce the same results، وبالتالي هتضطري تتعلمي انك ازاي تعملي تويكس وتحسني البرفورمانس. فاعتقد hunting a baseline published يعني would be a good start. ولو في اي حاجه ثانيه يعني personally I can propose to you some topics if you would like يعني او problems.
شكرا جدا يا دكتور. شكرا.
العفو.
اعتقد كده احنا خلصنا الاسئله. يعني لو في اي حد عنده اخر سؤال ممكن يرفع ايده ويسال دكتور مصطفى دايركتلي. اوكي. looks like يعني البارتس الاخرانيه كانت واضحه جدا، مفيش حد عنده اسئله. طيب دكتور، يعني انا احب اشكر حضرتك تاني على الوقت وال very rich presentation. هو حضرتك تقدر تشير معانا البرزنتيشن سلايدز؟ حد بيسال.
طبعا.
طب great. طيب احنا ممكن يا اما نبعتهم للريجستريشن ليست، يا اما ممكن الاسهل نحطهم على سلاك شانل. فلو ممكن تهاد تو ذا سلاك شانل اول لما دكتور مصطفى يشير البرزنتيشن هنحطها هناك.
سو انا بس محتاج اضيف بس شويه معلومات فيها، يعني في حاجات حاططها من غير ريفرنس، ف I need to make this يعني عشان ما يبقاش عليا اي مسؤوليه قانونيه. ف I would take some time، بس يعني ادوني وقت بس.
اوكي. ثانك يو دكتور، ناخد وقتك. ماشي. Again, thank you to the attendees. Thank you so much, Dr. Mustafa. Great presentation. I would like to just end this talk by announcing next week's webinar. Next week's webinar, let me just share my screen. Next week's webinar is by Dr. Walid Magdi, Associate Professor, Diversity of Edinburgh, Faculty Fellow of Alan Turing Institute. اتكلمنا عن فيلد يمكن كتير مننا ما يعرفوش ومش مين ستريم قوي، اللي هو Computation Social Science. I think يعني هيبقى addition و new information to a lot of people. لو حد عايز يرجستر، الريجستريشن لينك على البوست اللي شير دلوقتي، وهيبقى لايف على الفيسبوك بيج in a couple of hours ان شاء الله. اوكي. again شكرا جزيلا يا دكتور. احنا عامه هنبوست الريكوردنج بعد حوالي اسبوعين بعد ما الباتش الاولانيه تخلص من الويبينارز، هنحطهم على الويب سايت و it will be public to everyone to check. Okay, thank you so much يا دكتور. Thank you.
شكرا جميعا.
شكرا. الاسبوع الجاي ان شاء الله.
ان شاء الله. مع السلامه.
مع السلامه.